Namaste everyone. Greetings from Ganga Hospital and our anesthesia team from India. Today, I'm delighted to present on dual subsartorial block, a novel motor sparing block for total knee arthroplasty, highlighting the rationale behind our approach and its transformative impact on TKA surgeries. I also view this as an opportunity to proudly represent my country by highlighting a local technique and advocating for vocal for local, further extending it to local to global. Before we proceed, I affirm that there are no conflicts of interest or external sources of funding influencing this presentation. The visuals used are primarily from my own published works across various articles and chapters. While stakeholders such as surgeons, anesthesiologists, and patients may have individual objectives, our collective aspirations center around ensuring pain-free surgery, promoting satisfactory hospital stays, and facilitating suitability for enhanced recovery after surgery protocols. Let's embark on this journey of dual subsartorial block that began in June 2017, fueled by a passion for innovation and driven by the quest for better patient outcomes. It was built upon extensive research, drawing from numerous radiographic, cadaveric, and anatomical studies, all in preparation for a presentation at a prestigious RA workshop held in January 2018, where the concept of the dual subsartorial block was first introduced. This marked a significant milestone in our journey, setting the stage for further development and adoption of DSB. July 2019 marked a pivotal moment as we registered our first trial, embarking on a journey of experimentation and discovery. In December 2020, we published the results of our pilot study, validating the efficacy of the DSB. Throughout 2021, we made significant strides with anatomical and technical report, volume comparison study, RCT, and cadaveric research, solidifying the DSB's place in the field of regional anesthesia. The pinnacle of our journey came in October 2022 when our RCT on DSB was honored with the first prize at an international conference, affirming its impact and recognition. Looking ahead, we eagerly await a surge of publications, solidifying the legacy of the dual subsartorial block in regional anesthesia. First and foremost, let's clarify DSB. It's not just another routine block. It's a sophisticated regional analgesia approach, integrating two distinct blocks with precise modifications. These modifications are designed to offer procedure-specific postoperative analgesia for total knee arthroplasty surgery with medial approaches such as subvastus, midvastus, and medial parapatellar. This block may not be effective in other approaches. It offers comprehensive postoperative analgesic coverage, eliminating the need for supplementary blocks, making it a self-sufficient technique. Therefore, caution should be exercised to avoid administering DSB in conjunction with other active RA techniques, safeguarding its efficacy and promoting patient safety. Precise administration of the sequential injection is essential for achieving the desired effects and optimizing the distribution of the anesthetic solution. DSB is administered in the immediate post-op period after surgical dressing. Being an ultrasound-guided regional anesthesia technique, DSB requires a high-frequency linear probe with sterile covers in conjunction with a 100 mm block needle. Optimal results are achieved with a combination of 30 to 40 milliliters of 0.2% ropivacaine and 4 to 8 milligrams of dexamethasone as an adjunct. This technique entails two injections administered at two distinct locations, hence termed as dual, beneath the common muscular landmark sartorius, thus designated as subsartorial. The first crucial step is identifying the apex of the femoral triangle. This sets the foundation for accurate localization, ensuring optimal outcomes. Next comes the strategic deposition of local anesthetic solution into the distal femoral triangle and proximal adductor canal, lying just proximal and distal to the apex of femoral triangle. It's all about hitting those key spots with precision and purpose. Based on various research, anatomical correlations, and our extensive clinical experience with over 10,000 total knee arthroplasty cases since 2017, when we adopted the DSB as our multimodal analgesia protocol, we have developed a strong confidence in its effectiveness. DSB, being a motor-sparing, opioid-sparing, procedure-specific regional anesthesia technique, offers comprehensive post-op analgesia in TKA surgeries. In my presentation, I aim to demystify the intricacies of DSB by emphasizing the importance of understanding the relevant anatomy, sonoanatomy, and drug spread patterns in the thigh region. Knee joint innervation is divided into two components. Anterior knee innervations, derived from the lumbar plexus through its major branches. Posterior knee innervations, derived from the sacral plexus through its major branches. Before supplying the knee joint, these nerves form three different plexuses: subsartorial plexus, lying on the medial aspect supplying anteromedial knee and anterior joint capsule; peripatellar plexus, lying anteriorly supplying skin around the patella and anterior joint capsule; popliteal plexus, lying posteriorly, supplying all intra-articular structures and posterior capsule. The dermatomal and osteotomal innervation comes from the branches of the lumbar plexus anteriorly and the sacral plexus posteriorly. Notably, the anterior capsule of the knee joint is richly innervated compared to the posterior capsule by the articular or genicular branches that arise from the terminal branches of the plexuses. Proficiency in administering blocks that target all pertinent nerves supplying the knee joint relies heavily on a comprehensive understanding of two crucial anatomical landmarks within the thigh: femoral triangle and adductor canal, separated by the apex of the femoral triangle, which is the intersection point of the medial border of the sartorius and the medial border of the adductor longus muscles. The femoral triangle is a triangular subfascial space below the inguinal ligament, whereas the adductor canal is a musculo-aponeurotic tunnel encompassed by two muscles and one aponeurosis extending from the apex of the femoral triangle above to the adductor hiatus below. It is triangular in a cross-section, bounded anterolaterally by the vastus medialis muscle, posteromedially by the adductor longus muscle proximally and adductor magnus muscle distally, and medially by the vastoadductor membrane, a strong fibrous membrane joining the anterior and posterior walls. The nerve to vastus medialis lies outside the adductor canal above the VAM in a separate facial sleeve. The subsartorial plexus lies in this region, sandwiched between sartorius and VAM. The femoral triangle is a conical subfascial space that continues into the musculo-aponeurotic tunnel, leading posteriorly to the diamond-shaped popliteal fossa. This unique anatomical arrangement creates a visual impression of a funnel leading into a tunnel within the thigh. Therefore, the adductor canal serves as a passageway for structures that move between the front and the back of the thigh. The adductor canal consists of three foramina. The femoral vessels and the saphenous nerve enter the adductor canal through the superior foramen. The saphenous nerve and descending genicular vessels exit the adductor canal through the anterior foramen, piercing the VAM. Finally, the femoral vessels exit the adductor canal via the inferior foramen, also called the adductor hiatus, to become popliteal vessels. The nerve to vastus medialis lies outside the adductor canal above the VAM in a separate facial sleeve. These diverse anatomical connections divide the adductor canal into the proximal, middle, and distal adductor canal. Available literature exhibits discrepancies in defining and describing the femoral triangle and adductor canal, creating a perplexing scenario reminiscent of a triangle and tunnel of confusion. Despite numerous studies, a consensus on adductor canal block terminology remains elusive, impacting patient care. How does that matter to us? Wrong is wrong even if everyone is doing it, and right is right even if noon is doing it. The block level isn't just a technicality, they're the essence of patient care. Lack of precision can significantly affect analgesic efficacy, postoperative mobilization, and motor sparing effects. This ambiguity can lead to misinterpretations of study results, perpetuating misconceptions. Initially believed to be adductor canal blocks at mid-thigh, later found to be femoral triangle blocks, leading to incorrect attributions or credits to adductor canal blocks. Let's explore the various mid-thigh levels by marking a point on the apex of the femoral triangle and drawing a horizontal line across it. The midpoint of the anterior superior iliac spine to the base of the patella comes above the apex of the femoral triangle into the distal femoral triangle area. The midpoint between the greater trochanter and the base of the patella aligns with the apex or proximal adductor canal. Similarly, the midpoint between the mid-inguinal point and the base of the patella corresponds to the proximal adductor canal. Despite clear landmarks, misplacements persist, blurring the line between the adductor canal block and femoral triangle blocks. Blocks administered at the level of the apex of the femoral triangle are frequently mislabeled as adductor canal blocks. Only a handful of studies follow the correct nomenclature for adductor canal block, leading to a wide array of techniques and classifications. The flaws identified in previous RCTs not only perpetuate misconceptions but also cast doubt on the interpretations of all future meta-analyses, leading to the dissemination of inaccurate information once more. So what's the solution? Standardized nomenclature and technique description nullifying all previous faulty techniques. Preference of ultrasound guidance over surface landmarks to decide the territories of the femoral triangle and the adductor canal based on the precise sonolocation of the apex of the femoral triangle. Let's explore how it can be done. After holding the probe over the mid-thigh, the medial borders of the sartorius and adductor longus muscles are identified. Mark the point on the medial border of both muscles. Draw an imaginary line from the marked point of the sartorius muscle. If a point on the adductor longus muscle lies outside this line, it is the region of the femoral triangle, where the saphenous nerve and nerve to vastus medialis are separated by vasofemoral fascia. If both marked points come on the line, it is the apex of the femoral triangle, which appears as a sign of 3, also called a kissing sign. Suppose a point on the adductor longus lies within the imaginary line. In that case, it is the adductor canal, in which the vastoadductor membrane can be seen beneath the sartorius muscle, separating the nerve to vastus medialis outside the adductor canal from the saphenous nerve inside the adductor canal. Upon moving the probe from the proximal to the distal thigh, starting from the inguinal region up to the medial side of the knee joint, the sonoanatomical pattern changes due to varied anatomical interrelationships between muscles and the neurovascular bundles. While exploring different regions, the goal is to identify the apex of the femoral triangle, which is a crucial sonoanatomical landmark to demarcate territories of the femoral triangle above and the adductor canal below. As the sartorius muscle serves as a common landmark under ultrasound guidance, the region beneath this muscle in these areas is appropriately termed the subsartorial area. Thus, the femoral triangle and adductor canal blocks can be considered variants of the subsartorial blocks. With precise modification, the femoral triangle block constitutes one component of the dual subsartorial block, administered as the initial injection specifically in the distal femoral triangle region just above the apex of the femoral triangle. The presence of VAM is a peculiarity of the adductor canal region. VAM is nothing but the thickened fibrous connective tissues forming the medial border of the adductor canal. Due to this, the lower border of the sartorius appears bilayered in the adductor canal region. The injection at any point distal to the apex of the femoral triangle below VAM can be considered an adductor canal block. However, the involvement of neuronal components will be varied at various locations. The saphenous nerve enters the adductor canal in the proximal part but leaves in the middle part. So, it is not the content of the mid to distal adductor canal. The nerve to vastus medialis lies above the VAM outside the adductor canal. As a second injection of DSB, the adductor canal block can be given at any distance distal to the apex of the femoral triangle. However, we recommend giving this block in the proximal adductor canal area to avoid proximity to the sterile surgical site. Various dye studies in the subsequent years demonstrated the spread of dye in the popliteal area when injected into the adductor canal below the VAM. In contrast, dye injected into the femoral triangle remains confined under the sartorius muscle without reaching the popliteal region. The volume of the drug in the injection site significantly influenced the extent of spread into the popliteal region. Injecting 10 milliliters of the drug into the distal adductor canal can involve the popliteal plexus, whereas a higher volume of 15 to 20 milliliters is required for proximal adductor canal to achieve the same effect. Moreover, excessive drug volume injected into the true adductor canal may lead to accumulation in the popliteal fossa, initially affecting the popliteal plexus, followed by its mother branches such as the tibial nerve and common peroneal nerve, and eventually the sciatic nerve, particularly with volumes exceeding 30 milliliters. Let's explore how this spread occurs. When the drug is injected into the adductor canal below the vastoadductor membrane, it traverses through the adductor hiatus alongside the femoral vessels, which is nothing but the wider gap between the two heads of the adductor magnus muscle. Subsequently, the drug enters the popliteal fossa from the medial to the posterior thigh, spreading into the intermuscular plane and eventually affecting the sciatic nerve, depending upon the volume injected. This forms the foundation of the novel high-volume proximal adductor canal block, high-pack block, for Bologna surgeries, wherein a high volume of diluted local anesthetic is injected into the proximal adductor canal to involve the saphenous nerve directly and sciatic nerve indirectly. To achieve popliteal spread, the drug must be injected into the true adductor canal below the VAM, within the connective tissue compartment containing the femoral vessels and saphenous nerve, among the various described compartments of the adductor canal. Additional dye studies have consistently revealed the involvement of the nerve to vastus medialis in the distal femoral triangle block but sparing in the adductor canal block. Furthermore, injection of the drug in the distal femoral triangle can also involve medial and intermediate femoral cutaneous nerves and the nerve to vastus intermedius through the limited proximal spread beneath the fascia lata. After understanding all the intricacies, let's explore the technicality of DSB. So, DSB is administered in 3 simple steps. The first step is to identify the apex of the femoral triangle by locating the sign of 3. The second step is to locate the distal femoral triangle region, 2 cm proximal to the apex of the femoral triangle, for the first injection. The third step is to locate the proximal adductor canal region, 2 cm distal to the apex of the femoral triangle, for the second injection. To accurately locate the apex of the femoral triangle, it's crucial to identify the adductor longus muscle by sliding the probe up and down until the loop of the adductor longus muscle is seen under the medial end of the sartorius muscle. Then, align the medial borders of both muscles to form the sign of a 3 on the medial side. This alignment indicates the apex of the femoral triangle. To locate the distal femoral triangle region, the probe is moved 2 cm proximal from the apex of the femoral triangle. It can be appreciated by seeing the medial border of the sartorius and adductor longus muscle 2 cm apart. Once the desired point on the thigh is marked, the probe is moved laterally without moving up or down. After making the lower border of the sartorius prominent, the hyperechoic saphenous nerve and nerve to vastus medialis can be identified lateral to the superficial femoral artery. The needle is inserted in plane from lateral to medial direction. The goal is to place the needle tip immediately adjacent to both the nerves. Each nerve is individually targeted with 7 to 10 milliliters of local anesthetic solution due to the presence of vasofemoral fascia between them, which can impede the desired spread. Suppose the nerve to vastus medialis is not seen clearly. It can be identified by neurostimulation, keeping the needle tip between the sartorius and vastus medialis muscles, or by depositing local anesthetic solution separating the 2 muscular planes lateral to the saphenous nerve just below the lower border of the sartorius muscle. After completing the first injection, maintain the needle in its current position. Slide the probe 2 to 3 cm distally from the initial injection site. Next step is to locate proximal adductor canal for second injection. For that, the apex of the femoral triangle can be relocated by seeing a sign of 3. Now, move the probe an additional 2 cm distally to visualize the medial borders of the sartorius and adductor longus muscles, appearing 2 cm apart. This delineates the proximal adductor canal region. The distance between the needle entry points of the first and second injection should be more than 2 centimeters. The needle is inserted in plane from lateral to medial direction towards the superficial femoral artery. In this location, the lower border of sartorius appears bilayered due to the presence of the VAM. Furthermore, LA spread of the first injection can also be observed around the saphenous nerve, nerve to vastus medialis, and between the sartorius and vastoadductor membrane. Initially, the needle is targeted at the 10 o'clock position, and approximately 2 to 3 milliliters of local anesthetic is injected to hydrodissect the area. Subsequently, the needle tip is positioned at the 12 o'clock position of the artery, and 10 to 15 milliliters of local anesthetic solution is injected peravascularly below the VAM. Occasionally, compression of the artery may be observed while injecting, which is known as the sunset sign. After completing the second injection, local anesthetic spread at the desired regions can be confirmed by rescanning to identify the apex of femoral triangle and then to locate distal femoral triangle and proximal adductor canal. Local anesthetic spread around the saphenous nerve and nerve to vastus medialis should be confirmed by moving the probe proximally into the femoral triangle region and distally into the adductor canal region and by tracing the nerves from above downwards. Upon tracing, the nerve to vastus medialis can be seen outside the adductor canal above the VAM, separated from the saphenous nerve. The involvement of the subsartorial plexus can also be confirmed by seeping LA spread above VAM. Before understanding the LA spread pattern in DSB, let's explore the behavior of liquids or fluids when injected into confined spaces, surfaces, or tunnels. When injected into a tubular structure, the liquid naturally disperses evenly, occupying the entire volume of the tube if sufficient volume is available. If this tube is linked to a piston at the top, the fluid introduced into the piston chamber initially fills the lower section of the piston and then progresses into the connected tube. By introducing a partition within the tube, the liquid injected into the piston will be distributed uniformly on both sides of the partition. However, if an obstacle is introduced on one side of the partition, the injected liquid will preferentially distribute more on the unobstructed side due to the path of least resistance. As liquid fills the tube during the initial injection, subsequent injections into the partition tube will prompt the liquid to flow towards the area of least resistance, typically towards any available vent or opening. If we extrapolate the same concepts, we can understand the possible local anesthetic spread pattern of DSB. The first injection of DSB in the distal femoral triangle directly targets the saphenous nerve and nerve to the vastus medialis. The initial injection volume primarily occupies the distal femoral triangle area. Consequently, some portion of the drug disperses proximally within the femoral triangle, while another fraction enters the adductor canal alongside the femoral vessels. The majority of the drug flows toward the area of least resistance, progressing distally beneath the sartorius muscle but above the VAM. Spread within the femoral triangle region directly involves the saphenous nerve and nerve to vastus medialis, along with the medial portion of the peripatellar plexus, due to proximal dispersion. Whereas, distal spread above the VAM involves the subsartorial plexus. During the second injection of DSB, the spread pattern of the first injection can be visualized under ultrasound. The remaining volume of the adductor canal is predominantly filled by delivering LA paravascularly beneath the VAM. Any excess volume subsequently passes through the adductor hiatus, extending into the popliteal region to involve the popliteal plexus. Therefore, the combined effect of both injections can effectively target all necessary procedure-specific innervations when administered in the correct sequence and volumes. A similar drug spread pattern with the involvement of neural components was aligned with our unpublished cadaveric study. The clinical findings of our published volume comparative study and an unpublished RCT further support this observation. Additionally, our RCT demonstrated a superior analgesic profile of DSB compared to the femoral triangle or adductor canal block alone, along with a non-inferior motor sparing effect. Such spread pattern results in sensory blockade over the anteromedial aspect of the knee up to the tibial tuberosity, medial retinacular complex, and intra-articular region with the exception of the skin over the anterolateral aspect of the knee, which is supplied by the lateral half of peripatellar plexus and posterior aspect of the knee, which is supplied by the posterior femoral cutaneous nerve of the thigh. DSB is categorized as a procedure-specific block that involves both the anterior and posterior knee innervations, effectively addressing the innervation of all postoperative pain generators. Notably, the pain-generating components differ before and after surgery. Preoperatively, intra-articular components dominate pain generation due to inflammation from osteoarthritic changes in the joint. However, after TKA, all intra-articular pain-generating components are excised and replaced by non-neural and non-vascular implants. Thus, postoperatively, extra-articular components over the anteromedial surgical dissection area, which was healthy before surgery, dominate pain generation more than intra-articular components. However, the pain-generating components of arthroscopic knee surgery are mainly intra-articular, requiring similar analgesic coverage. Among all RA options from center to periphery for TKA, the analgesic coverage of each motor-sparing and era-suitable regional analgesia technique differs. By involving both anterior and posterior pain generators, the analgesic coverage of the DSB appears more procedure-specific than other available options. Several factors contribute to the motor-sparing effect of DSB. First is target. DSB precisely targets the terminal branches of nerves without compromising muscle strength. This precision is vital, as each nerve not only carries sensory signals but also gives rise to numerous muscular branches crucial for maintaining the integrity of muscle function. Moreover, the choice of local anesthetic like ropivacaine enhances its motor-sparing properties, administered at a low concentration of 0.2% to selectively target the outer sensory fibers of the nerve while preserving the core motor fibers. The volume of about 10 to 20 milliliters in the distal femoral triangle and 10 to 20 milliliters in the adductor canal region exhibited no clinical evidence of quadriceps weakness, while effectively maintaining analgesic efficacy. When combined with an adjuvant such as dexamethasone, known for prolonging the duration of selective sensory analgesia, DSB balances effective pain relief and motor preservation. However, anatomical determinants also play a role in restricting the proximal spread of the drug in the distal femoral triangle. Factors such as the conical arrangement of the thigh, increased muscularity proximally, gravitational effects, and relative resistance offered by the muscular thigh due to edema formation, often induced by tourniquet use during surgery, all contribute to limiting the spread of the local anesthetic proximally in the femoral triangle. Therefore, considering both anatomical determinants and pharmacological factors, DSB emerges as a motor-sparing regional anesthesia technique for TKA. Precision in modifications of injection techniques. Precision in choosing target sites. Precision in using fixed local anesthetic volume and concentrations. Precision in targeting selective postoperative procedure-specific innervations. Precision in achieving expected analgesic coverage without compromising the motor-sparing effect. Precision in the postoperative rescue analgesia plan, as per the precise pain mapping, makes the DSB a precision type of regional analgesia technique. When we compare DSB with other available and most discussed RA techniques, many factors, like complete procedure-specific analgesia coverage without the requirement of additional RA techniques, comparable motor-sparing and opioid-sparing effects, suitability to ERA's protocol, an anesthetist-administered technique without any reported fatal side effects, like last in LIA. DSB outweighs all available RA techniques. However, despite its novelty and relatively limited research, DSB warrants further discussion, studies, and evidence to establish its full potential. Thank you so much.